Okay. Hi, everyone. Welcome to the International Conference on Children and Their Families using the Multiple Indicator Classes Survey. I am Nazim Gashi. I am a GIS expert working with a UNICEF mixed team in headquarters, and we'll be sharing today's sessions on reproductive health. And my co-chair today is Gustavo Paez, data analytics from the regional office of South Asia. Before I introduce our speakers, a few words of housekeeping. This session will be recorded and hosted on the UNICEF Mix website and YouTube channel, as well as on the BPI, Bristol Poverty Institute YouTube channel, and embedded on the BPI website after the event. By attending, you consent to be part of this recording. Please ensure that you have added your name rather than being listed as a guest, as the team will be monitoring attendees and will also need to know who is asking our speakers questions. You'll be able to ask questions via the Q&A function, which is on top of your screen. And I'm kindly asking all participants to write down their question and not to raise their hands. So please write all your questions in the Q&A function. And if you have multiple questions, please write them down one by one in different messages and not all of them in the same message. Due to the time constraint, we may not be able to answer every questions, but please feel free to get in touch with speakers after the session to continue the conversation. Please note that the chat function is not available to attendees, so please use the Q&A function. And please be respectful. All events all at this conference are being monitored, and we reserve the right to remove attendees whose comments are deemed offensive or derogatory. In this session, we have two presentations. Each of them will last exactly 20 minutes. And after all these two presentations, we will continue with a Q&A, so with questions and answers. Now I give the floor to Sami Najmaddin Saeed from University of Debrecen in Hungary. And he's going to present analysis of antenatal care, intrapartum care, and postnatal care utilization. Findings from the 2018 Iraq mix survey. So, Sami, over to you. Thank you.
Thank you. Thank you for your introduction. And just give me a moment to share my screen. Is that okay?
Perfect.
Okay.
Yeah, perfect.
Okay. Good morning, good afternoon, good evening, everybody. Before I begin my presentation, I would like to thank the conference committee organizer for accepting our paper in this special conference and giving opportunity to present our findings with you. I also would like to briefly introduce myself and my colleagues as a co-author. So my name is Sami. I'm from Erbil Kurdistan region. I'm a fourth-year PhD student as a stipendium Hungary scholarship student in Doctoral School of Health Science, Department of Public Health and Epidemiology, Faculty of Medicine, Debrecen University in Hungary. And the co-authors are Professor Dr. Sándor János. He's the head of Department of Public Health and Epidemiology, Faculty of Medicine, University of Debrecen, Hungary. And Dr. Shayma, she's a gynecologist and lecturer at Department of Obstetric and Gynecology, College of Medicine in Howler Medical University. As you can see here, the title is Analysis of Antenatal, Intrapartum Care and Postnatal Care Utilization, Finding from the 2018 Iraqi Multiple Indicator Cluster Survey. The presentation, the content of the presentation includes introduction, objective, methodology, result, and conclusion. I hope we can cover all the parts within the time periods given. So let's start with the introduction. We all know that maternal newborn health are closely linked to, so the reducing maternal mortality and morbidity is now globally considered. That's why the first two the first two targets of Sustainable Development Goal of health and well-being related to maternal newborn health. and also target 7, which is related to sexual and reproductive health. So going back to that target 1, which is aiming to reduce maternal mortality ratio to less than 70 per 100,000 live births by 2030. So considering these trends, considering this target 1 in Sustainable Development Goals, I brought some data and trends regarding this. So as you can see here, the maternal mortality ratio in the last 2 decades at all levels, in the global, regional, and country level, in the global level is declined by 34.3 from 339 to 223. In Northern Africa and Western Asia from 159 to 84. In Iraq, in the national level is about 170 to 76. So the overall reduction in Iraq is 36. So moving to the cause of maternal death, a systematic analysis study conducted by WHO, which includes 23 studies and 470 data set from 115 countries, reported that the direct obstetric causes about 73%, while the indirect obstetric causes are more than quarters. So it's also reported that severe maternal morbidity causes maternal mortality. And alone that, if we just take the hemorrhage and hypertensive disorder and sepsis, were responsible for half of the deaths of the mothers. So most of the maternal neonatal deaths can be prevented if we can provide the healthcare services by skilled health professionals before the pregnancy, during the pregnancy, and after the pregnancy, which we called continuum care. Our objective in this study, the overall objective is to analyze data on antenatal, intrapartum, and postnatal care utilization, focusing on women in reproductive age in Iraq using mixed data. Our specific objective is to determine the prevalence of antenatal, intrapartum, and postnatal care, and to determine the factor associated with all outcome variables. So our methodology in this particular study, we use the secondary data analysis from the 2018 mixed data, which is round 6. It is a nationally representative cross-sectional survey. So the sampling techniques, the sampling strata were defined as urban, rural area in all 18 governorates in Iraq. A multi-stage stratified cluster sampling were approached. Our analysis was restricted to 6,250 women in childbearing age who had a live birth within 2 years preceding the survey. Our outcome variables in this study were measured as a binary, like this, do they receive antenatal, for example, or not receive it? So these created from the multiple question asked women in that mixed data. Our independent variables were obtained from both women's data and household data after merging these 2 data sets using mixed guidelines for merging the data. So all these variables you can see here, maternal age, age at first marriage, place of residence, wealth index, religion, maternal education, so on. In statistical analysis, we handled our missing data using the complete case analysis. So we did not use any substitution for the missing data because the proportion of the missing data is below the 5%. So we ran the complex survey analysis for both descriptive and inferential statistic. In bivariate analysis, we use chi-square test to associate between the dependent variable and independent variables. After checking all the assumptions for running the multi-variable logistic regression to identify significant factors associated with the outcomes, we approach our result here. So as you can see here, the prevalence of antenatal care is 67.7, which is the lowest rate, and intrapartum care is about 86.5, postnatal care for mothers, 83.6. Postnatal care for babies, 80.6. So here I'm referring you to the Word document file, which contains all the bivariate and multivariable logistic regression. I'm not going to explain everything in that Word document. I only show you the our main findings. So as you can see, just in bivariate analysis here, I don't know if you can see properly or not. Can I make it bigger or anyway? So you can see this is our chi-square test. For most of the variables were significant significant with the outcome variables in the chi-square test. Here, as you can see we bold it, so the significant is bold. You can see. So let's jump to our main finding in multivariable logistic regression. See. Let me just adjust. In the first model, I mean in antenatal care, so all the variables we included here is around, like, let me just check. Yeah, 17 variables. Most of them, they were significant, like maternal age. So being maternal age at age under 18s, and those women living in rural area, and women with a household in a poorest category, maternal education, so low level of maternal education and household head education. Mass media, those women who does not have access to mass media, and estimation of overall happinesses, which means those women who's very unhappy, having more children, husband with more wife, with those women who live with the husband who has multiple wives. So this has had a reduction in the odds ratio of antenatal care, which means that those factors were less likely to have antenatal care. While similarly for the intrapartum care, we have also the education, living in rural area, as you can see here, happiness also, living with, the polygynous marriage, and antenatal attendance. If the antenatal attendance is below 4 visits, they're less likely to have intrapartum care, except for we have those women who live in Kurdistan region, they are more likely to have the intrapartum care. As you can see, the odds ratio for those women who live in Kurdistan region is almost 7 times higher than those who live in the central and south part of Iraq. As for the postnatal care and postnatal care for both mothers and their babies, you can see again we have a wealth index and education level, again mass media. So all these factors were, as you can see here, the attendance, antenatal care attendance, antenatal care visit initiating of those women who initiated their antenatal care in the late booking, in the second or third trimester, were less likely to have postnatal care for both mothers and their babies. So time of breastfeeding, only those factors like health facility, I will just show you here, and delivery by cesarean section, as you can see here, more likely to have is postnatal health care for babies and mothers compared to those who deliver in home. So those who deliver by cesarean section is 5 times higher, and by delivery by normal is 2 times higher compared to those who deliver in home. And we also, those women who delivered boys newborn were more likely to have postnatal care. You can see here the odds ratio is 1.2. So just going back to our PowerPoint presentation, sorry. So here, after all that we said, we can conclude that the poor maternal health associated with the factors living in rural area, education for both mothers and household head, low education, I mean, and those women who married at the age of under 18s, and having no access to mass media, and wealth index a poor category, in being very unhappy, having more children, inadequate antenatal care and initiation, and those who stay less than 6 hours in the health facility after childbirth, and no breastfeeding, those who do not breastfeed their babies. While the factors like women in live in Kurdistan region, delivered by cesarean section and delivered in health facility, more likely to have the maternal health care. So all these factors have a public health important and sufficient enough to inform the healthcare decision makers to divest maternal and newborn health care and formulate. Additionally, so addressing these disparities needs to promote equitable access, standardize the maternal health protocols, improve access to healthcare, and ensuring consistent support regardless of the socioeconomic status. Thank you.
Thank you very much, Sami, for this great presentation and great work. And now we will pass the floor to Rie Fuse from Keio University, and she's going to present the trends and factors associated with contraception among married Palestinian women, a cross-sectional study from mix 2010, 14, 19, 20. So Rie, over to you, and I hope you can have your microphone close to you so we hear you well. Thank you, and over. Perfect, we can see your screen.
Good morning, good afternoon, good evening, and thank you for taking time to be here.
Sorry, your voice is echoing, it's like robots.
Oh.
If you just put it a bit more closer to you.
Okay. It's okay?
Yeah.
Okay, sorry. Again, and good morning, good afternoon, good evening. Thank you for taking the time to be here today. My name is Rie Fuse, a PhD student here at University Graduate School of Health Management. And today I will be presenting on trend and the factors associated with the contraception among married Palestinian women, a cross-sectional study from mix 2010, 14, and 1920. That background, reproductive health implies that people are able to have a satisfying and safe sex life, and that they have the ability to reproduce and freedom to decide if, when, and how often to do so. Family planning can support individual decisions by using contraception methods and the treatment of infertility. Focusing on contraception, the use of the contraception plays a crucial role in protecting the health of women and children. For example, contraception use is associated with the reduction of maternal deaths, premature births, and baby low birth rate. Shifting the focus on the state of Palestine, reproductive health has been affected by the conflict. Even in this situation, the indicators both maternal mortality rate and underfed mortality rate have improved. In addition, the unmet needs for contraception has decreased from almost 60% in 2010 to almost 30% in 2019-20. On the other hand, the use of contraception was associated with a lack of knowledge in decision making on health workers' skill. And how contraceptive use and associated practice have changed over time. So limited study compared the multiple years based on a national survey, including English tribe. This study examined the trend of the contraception and the factors associated with the using contraception in 2010, 14, and 1920 in Palestine. We have two objectives of this study. First, to explore the trend in using contraceptive methods among women who don't desire pregnancy at this time. Second, to explore the associated factors with using contraceptive methods among those who don't desire pregnancy. About the method, the research design was a cross-sectional study. We used the 3 data sets shown in the slide. The target population is discussed on the next slide. The outcome variables was whether contraception was used or not. Also, the explanatory variables are the same 5 questions asked in each use. We use the SPSS version 29 for the data analysis. It strictly summarize the variables, and the Reproductive was used to analyze the unvariable association between contraceptive use and these variables. The example of multipolarity between explanatory variables in the multivariable model. We use a variance implemented factor VIF. Due to the estimated VIF for one explanatory variable was over 10, we judged there was a strong possibility of the multipolarity in the multivariable model. And when I logistic regression analyzed the association between contraceptive use and each variable. The significance level was set at 0.5. About the target population, the mixed question on the contraceptive use were asked among women on the reproductive age, married and non-pregnant women only. Also, the response item for given for not using contraception include desire to have a child. However, this time we exclude this item, desire to have a child, because we wanted to focus on those who didn't desire pregnancy. And so in account the contraceptive intention was facing the limiting the number of children. Also, item in the response categories of the menopause, having received absence of husband and breastfeeding were excluded due to the physical and social background. Finally, it was weighted and for the number of the people in which year was calculated. Using 2010 as a reference point, the population has increased into the 90% range in each following years. Focusing on each governorate, we identify the change in contraceptive use. First, in response, based on 2010, contraceptive use were increasing some governorate, while in others it was decreasing, and there were governorate differences. Secondly, about the Gaza strike, it was found that contraceptive use increased recently over time, although there has been decline in some governorates. Next are the result of the association factors. Binary logistic regression analysis was used to determine the strength of the association between contraceptive use and variables. Also, there are no evidence for multipolarity in the multivariable model by the estimated VIF. Adjusted odds ratio showed that in 2019, age and the region were positively associated with the contraceptive use. In addition, in 2010, the web index and 2014, the count lessons are associated with the contraceptive use. However, no statistical significant association was found in 2019. Discussion part. First, the availability
Sorry,
of
Rie,
contraceptive.
excuse me.
Hi.
Yeah.
What?
And now if you keep your mic like this, it's much better. If you keep it as close as
Much
you can,
better.
okay?
Okay.
Yeah,
It's
thank you.
okay. Thank you. Sorry. Next discussion part. First, the availability of contraceptive method has improved over the past 10 years, especially in the Gaza Strip. The UNRWA, United Nations Relief and Work Agency for Palestinian refugees in the Middle East, has been responsible for the healthcare of Palestinian refugees, including family planning services. Previous study has shown that accessibility of the health services is associated with the contraceptive use. The availability of health services close to women in Gaza, right, may have influenced the presence results. Second, contraceptive methods are pervasive regardless of socioeconomic demographic background. Previous study have shown that the socioeconomic status like age, education level, and residence area were associated with contraception. But the analysis found a positive association between the contraceptive use and was indexed in 2010, but no such association means experience years, regardless of the individual background. It may be becoming possible to choose the use contraceptive method. Finally, acknowledgement. Thank you for your kind attention.
Thank you. Thank you, Sami and Rie, for your great presentations. And I wish you luck on continuing your researches. So now we open for questions and answers. If you have any question, please write them down in the Q&A function. We don't have any question at this moment, but please, if you have any, just write it down there and we can read it and ask the speakers. And I'm sure that I can speak in their names. And if you want to reach them later, you can do that to both speakers if you have any question and you would like to continue the discussion. In the meantime, if there is any question, and if not, I have two questions on my own that I want to raise it to both the speakers. So I know the survey in Iraq was the latest is 2019, right? And
18.
for 18, sorry,
yes.
and for Palestine is 1920. So I just wanted to know if this first, if this work can be replicated in other surveys. So this question is for both of you. I mean, if there are plans on replicating this work on other countries and other surveys. And then the second question is if we can, so how can the next mix help in kind of having longitudinal analysis on this? So like the latest is 2018 for Iraq and 1920 for Palestine, but now it's 4, 5, 6 years old, the survey. So, and we know plans are to continue with the next mix in both countries. And just asking if we can do longitudinal analysis. Okay, over to Sami first, because you're the first presenter, and then to Rio. Okay?
Okay. So in terms of the next, the next mix data collection will be, I think, in the next year for the Iraq. So what is because it's been a long time, like 7 years from now, so to conduct the new mix data. So, that mix, I mean, our data we use for this paper, which is mix 2018, which is just, conducted after the conflict in Iraq, because, Iraq, many things is destroyed due to the terrorist, activity like and insecurity in Iraq is not good, and everything was collapsed, because I do remember when I was working with the Oxfam GB as a public health team. So many health facilities were destroyed especially in the central part of Iraq. So I think nowadays, as you can see in my result, you see there is a difference between those women who live in Kurdistan. They have more likely to have intrapartum care compared to those who are living in south or central part. So I think this conducting the new study will be much important to see how the situation and how the trend in Iraq and what will be in the future, and because nowadays a bit stable compared to the previous mix. So in terms of the research and longitudinal study, also we need to consider that our finding to check, we need for further research to conduct qualitative study in order to identifying or understanding the barriers why this disparity we have for this, in terms of the utilizing and maternal health care. I don't know I answered your question properly, or if it's still not, I might be able to.
Yeah, this was clear, and the other was if you have plans on replicating this work in other countries, in other surveys.
You mean for myself?
Yeah,
absolutely.
for you and your team, of course.
Yeah, you know why this data is internationally validated, and it's not simple to collect the data by myself. For example, it is supporting with the government, with the UNICEF mix team, and it is as I said, it's internationally validated, and it's more generalized, so it's easy for us to get this data. I forget to thank you, UNICEF, to providing this data. I'm definitely, we go to have a plan to get new data, and we do have a plan with Professor Dr. Sándor János to have, the previous data compared with the new data, with the current data, to have, to check where we are and what we need to be done in terms of the maternal health care. Yeah, definitely we are going to use this data. Yeah. Something. Yeah.
Yeah, thank you. Over to Rie now. Rie? And I see we have a question in the chat, but we will raise that after the response. Okay.
Okay. Oh, and the Palestine, the conflict setting, Palestine continue the conflict setting. But the reproductive health is fundamental to health and human rights. So as soon as the word finish, so the reflection start.
Can you put your microphone closer? Yeah.
Yeah.
Yeah. So if you can answer again, because we couldn't hear you.
Sorry, the Palestine continue the conflict setting now in West Bank and the Gaza Strip, but the reproductive health is fundamental to health and human rights. So, if after finishing the word and the data collection starts, I think.
Okay, we have a question in the chat from Gustavo, and I think it's from Yuri, for Yuri. So the changes between Palestine years, are they statistically significant? The bars presented point estimators, but there are no confidence interval. So it is unclear if those changes have a meaning or a product of the randomness. So I hope you heard me, Rie, but you have the question in the chat as well.
Thank you for your valuable question. And sorry, we cannot analyze the change between Christian years. So I and will refer to it.
Okay, I think you can follow up on this with Gustavo if needed. If there is any other question, please write it down, or we can close a bit earlier than supposed. Well, I think it's fine if we spare some minutes to our lives. Please, if you have any question. Okay, 1, 2, 3. Okay, thank you very much again for this wonderful presentations. Thank you to all the participants for participating. And just a quick reminder that this event has been recorded and will be available via the Mix program and DPI website after the event, where you can watch it back and or share it with the link with friends and colleagues who may be interested in watching. You can, of course, also catch up with any of all the conference sessions which you may have missed. You can watch them in after the conference in YouTube and our websites. So thank you very much, and I wish you a good day.
Thank you so
Thank
much.
you.
Thank you. Bye bye. Bye. Thank
Bye.
you.